Hello.
Hi, ma'am. Good evening.
Hi, good evening. Can you make me the co-host so I can
One
share?
minute, ma'am.
Yeah,
1 minute. Yes, ma'am. I have make it the co-host, ma'am. You can share the screen and start the class, ma'am.
yeah. Hello, also we are going to discuss the genitourinary part 1. In this lesson, we are going to rapidly revise all the topics which are asked in your exam, all the questions, and we are going to also cover a few MCQs. Mostly, we are going to discuss high-yield topics for the university exams. So we have long essay questions and short essay questions for us. Okay, so these are all what we are going to discuss, and also I'm going to discuss a few MCQs regarding all these lessons. In Oracle, we have recorded classes, live classes, practical sessions, exam modules, and also hard copy books. The recorded classes have it's very useful for flexible learning and convenient revision. Live classes have in-depth coverage and it's focused on interactive learning. Express exam module has all the questions which will be asked in your exam covered quickly so that you can go ahead and revise it in just 20 hours. There are personalized learning sessions, one-to-one doubt clearing sessions also. Hard copy books are very easy for flexible learning. Question banks are of different grades and different difficulty levels. Practical sessions are very unique. It can simulate a normal practical exam and also gross scenarios and clinical scenarios can be simulated. These are the subscription plans which you can find in the website. Okay, so in this lecture, we're going to discuss kidney pathology. The first question which we're going to discuss here is glomerulonephritis. Okay, glomerulonephritis can be roughly divided into two types: primary glomerulonephritis and secondary glomerulonephritis. Primary glomerulonephritis occurs without any prior condition. For example, it is a primary kidney disease. Few examples are minimal change disease, focal segmental glomerulosclerosis. Secondary glomerulonephritis usually occurs as a part of a systemic disease. The patient already has a systemic disease, kidney involvement is secondary. So, a few examples of that is lupus nephritis and diabetic nephropathy, where the patient already has lupus nephritis and diabetes, which further goes ahead and involves the kidney. So, this is the basic difference between a primary glomerulonephritis and a secondary glomerulonephritis. So, I want you to know two types of clinical syndromes, which is nephritic syndrome and nephrotic syndrome. Why is this important? This is important because you have to know the clinical features to understand what would be the effective pathological feature in that. So there are a few clinical features which will be helpful. So when you get a case-based question in kidney also, you can look for these features to identify what scenario or what pathologic disease they're expecting you to answer. So first is nephritic syndrome. Nephritic syndrome, you're going to have hematuria and hypertension. Okay, these are the main features which you have to look for in a nephritic syndrome. You're going to have hematuria and hypertension. Proteinuria is going to be there, but not very significant. So less than 3 grams of protein is going to be there in the urine. Nephrotic syndrome, on the other hand, is going to have more than 3 to 3.5 grams of protein in the urine. So it's going to be significant proteinuria. Okay, so this is very important. Significant proteinuria is very important. Since we have protein in the urine, what is going to happen? Albumin is going to decrease and then there is going to be generalized edema. Okay, generalized edema because protein levels are low. And this edema type is going to be transudative generalized edema in nephrotic syndrome. So why should we know this? There are a few renal conditions which are specifically associated with nephrotic syndrome and nephritic syndrome. For example, in minimal change disease, we have nephrotic kind of proteinuria and generalized edema. Also, focal segmental glomerulosclerosis is associated with a nephrotic kind of clinical presentation. Whereas IgA nephropathy, post-streptococcal glomerulonephritis, these are predominantly associated with the nephritic range proteinuria and nephritic range syndrome. So, this will be useful for you when they give you a clinical case and ask you to identify the condition, and further they might ask you to identify the pathogenesis and all the pathological features also. So here we have a stepwise approach for nephritic syndrome versus nephrotic syndrome. If the patient has hematuria and or proteinuria, so remember whenever the patient has hematuria, whenever you get a clinical case with hematuria, always think of nephritic syndrome. Okay, so hematuria, always think about nephritic syndrome. And does the patient have glomerular hematuria? That is RBC positive, dysmorphic RBCs in the urine. So yes, so if the patient has hematuria, you're thinking of nephritic syndrome, right? So there's going to be glomerular nephritis. So what are the types of glomerular nephritis which are associated with hematuria or nephritic syndrome? We said nephritic syndrome is going to have hematuria, hypertension, and proteinuria, which is less than 3 or 3 grams per day, right? So linear, we have certain conditions which are associated with nephritic syndrome, which is anti-GBM disease or Goodpasture syndrome, post-streptococcal glomerulonephritis, membranoproliferative glomerulonephritis, IgA nephropathy, and other quasi-immune diseases, which is vaginal granulomatosis with polyangiitis, and things like that. Okay. If proteinuria is there and significant proteinuria is there, which is more than 3 to 3.5 grams per day, then you have to think of a nephrotic range proteinuria. In nephrotic range proteinuria, there is going to be decreased albumin because protein is excreted, and along with it, obviously the major protein component is albumin. It's going to be excreted. So hypoalbuminemia. Hypoalbuminemia is going to lead to edema. Okay, peripheral edema. So what are the types of diseases which is going to cause kidney conditions going to cause this? It is minimal change disease. As I already said, FSCS, focal segmental glomerulosclerosis, membranous, membranoproliferative, diabetes, and also amyloidosis. So this small difference will give you a lot of edge when you read clinical cases to identify the condition. Now we're going to see a few ways where glomeruli is getting injured. Okay, so we know that there are a few types of injury which is going to happen. First injury, few types of injury. First is directly some kind of damage is happening to the food processes. Okay, so these are the food processes. They are also known as podocytes. So these are the main food processes are main for absorption of protein. So food process damage is going to happen. The second most important type of injury which is going to happen is antibody mediated injury. And then we have injury which is due to some deposition of amyloid, okay, substance deposition, or in so this is known as deposition disease. Okay, Okay, so any substance which is going to get deposited. Okay, so because of organoid deposits. So these are the three types of injury. One is because of damage of our food processes, physical damage, and then we have antibody mediated damage, and then because of deposition. These are the three main types of damage which is happening. So damage of food processes, you have to remember minimal change disease and FSGS. In these two conditions, you will see a effacement of food process. Right. As I already told you that our food processes are what is responsible for protein absorption. Okay. So when food processes are effaced, naturally protein absorption is going to get impaired and you're going to have proteinuria and you're going to have nephrotic range proteinuria. Okay. So nephrotic range proteinuria is going to happen when food processes are effaced. So that is why now you can correlate that you have nephrotic range proteinuria and what are the conditions which are responsible? Minimal change disease and FSGS cause nephrotic range proteinuria. What is the pathophysiology behind it? It is effacement of food processes. Okay. The second type of damage is antibody mediated damage. So antibody mediated damage can be either because of circulating antibodies, which are immune complex deposition, that is circulating antigen and antibody both are in the blood, they're circulating and they come and deposit in the glomerulus. So this is the circulating type of antibody. The second type of antibody deposition is in situ deposition, that is antibody is in the serum, antibody is forming, but it is reacting against a particular antigen which is present in the glomerulus. For example, it is reacting against a particular antigen which is present in the glomerular basement membrane and it is attacking the glomerular basement membrane. This is seen in anti-GBM disease. Anti-GBM disease, which is also known as Goodpasture's syndrome. So, we have anti-GBM antibodies and Cayman antibodies. So, immune complex deposition, right, because of circulating antibody and in situ deposition, which can be seen in anti-GBM disease. And the third type of injury is because of deposits. Okay, deposits of, for example, amyloid. Okay, if amyloid gets deposited in the food processes, again, what is going to happen? There's going to be impairment of protein absorption. So when there's no protein absorption, again, there's going to be proteinuria. So even amyloid can result in a nephrotic range proteinuria, which is more than 3 grams per day. So even deposition diseases can affect the food processes because they get deposited and impair the absorption of protein, leading to a nephrotic range proteinuria. So this is a simple concept which you have to remember regarding glomerular injury. Now, certain types of diseases have very peculiar and very specific type of deposits over here. Okay, so you can see here, this is the epithelium. Okay, this here is the epithelium. Okay, and then here, this is subepithelium. Okay, below the epithelium, and this is the endothelium. Okay, and here you can see that this is the glomerular basement membrane. Okay, and then here we have other kind of deposits which are in the mesangium. This is the mesangium where blood vessels are there. This is the mesangial area. This is the mesangium. Okay, so we can see there are certain types of deposits which are here in the epithelium. Okay, this is also here in the epithelium. This is in between the epithelial area. This is inside the epithelium, and here we can see that these deposits are below the epithelium. This is subepithelium, right? So there are different types of deposits. There is a mesangial deposit also. So I'll tell you what diseases will cause which kind of deposit, which is also very characteristic. Okay, so we'll read that further. Now these are a few examples of glomerulonephritis. So the first important glomerulonephritis is post-infectious glomerulonephritis. We already saw it is associated with nephrotic syndrome, and there can be circulating immune complexes. In light microscopy, what you can see is diffuse endocapillary proliferation. There will be proliferation. Okay, and then there is going to be IgG and C3 deposits in the glomerular basement membrane. Mostly these are going to be subepithelial deposits, or they are also known as subepithelial humps below the epithelium. So you can see here that below the epithelium there are few deposits over here. These are subepithelial deposits. And these subepithelial deposits are what are seen in post-streptococcal glomerulonephritis. Okay. The second type is crescentic glomerulonephritis or rapidly progressive glomerulonephritis. This is also associated with nephrotic syndrome. There are lots of causes for this. We have anti-GBM antibody, which I already discussed, antibodies against the glomerular basement membrane, and many other immune complex mediated diseases can be a cause for this. Linear deposits will be seen in the anti-GBM antibody. We know that the deposits, the antibodies against the glomerular basement membrane. So the pattern is going to be linear deposits when we do an immunofluorescence. Okay. Next is membranous nephropathy. We know that membranous and minimal change disease and also focal segmental are predominantly nephrotic range diseases. So this is a nephrotic disease. The cause for pathogenesis includes flower antibody, flower antigen, which is actually present in primary cases of membranous nephropathy. In light microscopy, there is diffuse capillary wall thickening and granular immunoglobulin deposition. Here also we can see subepithelial deposits. As I already said, there were subepithelial deposits in PSG, and also in membranous glomerulonephritis, we can see subepithelial deposits. Okay. Next is minimal change disease. Minimal change is a very unique kind of disease where you cannot see, it's a nephrotic range proteinuria, but you cannot see any changes in the light microscope, and in electron microscope, there is effacement of food processes. Focal segmental glomerulonephritis, also a nephrotic range proteinuria. Okay, and there can be some immunodeposits and effacement of food processes can be seen similar to minimal change disease and focal segmental glomerulonephritis. Next here is membranoproliferative type 1. In membranoproliferative type 1, we're going to have nephritic as well as nephrotic. Both can be present. And this is also immune complex mediated disease, and you can see immunoglobulin deposit, which is subendothelial deposits. It's not subepithelial deposits. Okay, we can see here that endothelium is over here. So you can find deposits somewhere over here. This is the epithelium and this is the endothelium. You can find deposits somewhere over here in membranoproliferative diseases. And then next we have mesangial. Okay. Dense deposit disease is also there, which is a nephrotic range disease, and you can see dense deposits in electron microscopy. IgA nephropathy, again, we discussed that this is a hematuria based disease and there is a nephritic range disease, and we can see mesangial and paramesangial dense deposits. So whenever you see mesangial deposits, it's going to be IgA nephropathy. Okay. So these are the few things which you have to remember. There is subepithelial deposits, humps, which are seen in PSGL, subepithelial deposits in membranous nephropathy, subendothelial deposits in membranoproliferative disease, and then paramesangial and mesangial deposits in IgA nephropathy. So now we are going to discuss post-streptococcal glomerulonephritis. This is an immune complex deposition-based disease which can cause inflammatory reaction, right? So there is diffuse proliferation of the glomerular cells. This is the major important thing which you have to remember, which is diffuse proliferation of the glomerular capillaries. So there is increased proliferation. In electron microscopy, as I already said, We have a glomerulus here, and there is epithelium, and there are subepithelial deposits, which are humps. So subepithelial humps are characteristic of post-streptococcal glomerulonephritis. The ideal history of post-streptococcal glomerulonephritis is going to be, you're going to have a pharyngitis. Okay, there's going to be a pharyngitis, and then after a few days, you're going to have a glomerulonephritis. This is the ideal scenario. Okay, this is the ideal scenario of post-streptococcal glomerulonephritis. Streptococcal pharyngitis followed by glomerulonephritis. Right? Now here is a case. Okay, this is very clear cut. This is a 10-year-old girl with hematuria. Very clear cut. Right, and then there is oliguria. So they have given us hematuria. So thinking they have given us hematuria, the first thing we have to think is nephritic, right? So we do not have hematuria in most nephrotic cases. So this is a nephritic syndrome. 10-year-old girl they have given. And what are the other findings which is there in this girl? There is hematuria, oliguria, moderate hypertension is there, red cell cast, mild proteinuria, elevated. So two conditions we have to think when they give us a history of hematuria with the nephritic range proteinuria. Nephritic range, I think they have given hypertension also. So one is IgA nephropathy. And the second one is post-streptococcal glomerulonephritis. So the main clue to identify which of these diseases is post-streptococcal glomerulonephritis, as I already said, presents with pharyngitis. Right. IgA nephropathy has a viral infection which can actually predispose to IgA nephropathy. So a prior viral infection if they had given, so it would predispose to IgA nephropathy. Since this is not given in this condition, we're going to just, if they had asked, we have to just say that these are the conditions which are possible. So in this case, as we said, we have IgA nephropathy also and post-streptococcal glomerulonephritis also. So we have to discuss both of these conditions and say the clinical features and pathological features of both of these conditions, which we have already discussed. IgA nephropathy, as we know, has mesangial proliferation. Okay, mesangial proliferation. Post-streptococcal glomerulonephritis has C3 and IgG deposits. Subepithelial region, proliferation of capillaries, right? External proliferation, mesangial proliferation in IgA nephropathy, and mesangial and paramesangial deposits. So these are a few key points which you have to remember. Now we'll go ahead and discuss the next question, which is adult polycystic kidney disease. Most important adult polycystic kidney disease is autosomal dominant disease, and we have mutations in PKD1 and PKD2 genes. There are multiple cysts which are actually seen in adult polycystic kidney disease. Okay, what are the complications? Hypertension, renal failure could be the complications of adult polycystic kidney disease. It's also associated with berries and urine. Okay. And also remember a few points about autosomal recessive polycystic kidney disease, which is autosomal recessive polycystic kidney disease, which is usually seen in children. Okay, the cysts which are there, you can see here in adult polycystic kidney disease, the cysts are larger in size. Okay, in autosomal recessive kind of polycystic kidney disease, the cysts are very smaller in size. Okay, and these are associated with hepatic fibrosis also. Congenital hepatic fibrosis. Adult polycystic kidney disease will present with hypertension in adult stage. It can lead to renal failure. Also remember the association with berries and urine. Remember the mutations PKD1 and PKD2, and adult polycystic kidney disease is an autosomal dominant condition. These are a few points which you can write in the short notes. Now we'll discuss nephritic syndrome. We've already discussed differences between nephrotic and nephritic syndrome. In nephritic syndrome, we're going to have hematuria, hypertension, and oliguria. Okay. So, of course, and then we are going to have proteinuria, but proteinuria is going to be less than 3 grams per day. If it is more than 3 grams per day, then it is going to be nephrotic. Okay. So, histopathology, we have to know what are the conditions which are associated with nephritic syndrome. So, as we already discussed, we are going to have IgA nephropathy, which is associated with nephritic syndrome. Correct? PSGN associated with nephritic syndrome. We can write the key features which are associated with IgA nephropathy and post-streptococcal glomerular nephritis. We are going to have anti-GBM disease, which is also known as Goodpasture syndrome. Okay. We can write a few lines about this Goodpasture syndrome, which is nothing but it is autoantibodies against the glomerular basement membrane. There are not going to be any deposits, but when you do an immunofluorescence, you're going to have linear IgG deposits. Okay, because we know that the antibodies are mediated towards the glomerular basement membrane. So that is what you're going to see in this. And then we can also have pauci-immune diseases. Like we have 3 important pauci-immune diseases which are nephritic in nature. First one is microscopic polyangiitis. Microscopic polyangiitis. These diseases are also ANCA-associated diseases. Microscopic polyangiitis, we're going to have another disease which is known as granulomatosis with polyangiitis. Okay, this was known as Rickner's granulomatosis, and then eosinophilic polyangiitis. This disease was known as Church-Strauss disease. So these are all ANCA-associated conditions. Also remember, microscopic polyangiitis is P-ANCA-associated, and polyangiitis with granulomatosis is C-ANCA-associated, and these are known as pauci-immune conditions because they do not have much immune deposition in the kidney. So that's why pauci means less because they are ANCA-associated, right? So these are the few nephritic related conditions which you can remember. Now we'll discuss a few MCQs regarding to the topics which we have discussed. First question is, which of the following characteristic feature of post-streptococcal glomerular nephritis is seen in electron microscopy? Right? Subepithelial humps. This is very easy. Right? Subepithelial humps was the important feature which we had seen. Subendothelial immune deposits, in which condition did we see? Subendothelial immune deposits, it was type 1 MPGA. Correct? Mesangial deposits in which condition? IgA nephropathy. No immune deposits, minimal change disease. There are many conditions, but minimal change disease is very frequently associated with no immune deposits and no light microscopic changes. Also, you can say in pauci-immune diseases, there are not much immune deposits, right? ANCA-associated conditions do not have much immune deposits. So that could also be one of the answers. Okay, so this is a process of elimination. You can also follow it this way. What is the genetic basis of adult polycystic kidney disease? Okay, so we have PKD1, PKD2 genes. We have already discussed that PKD1, PKD2 genes is associated with adult polycystic kidney disease. Now, mutation in HLA-B27 is associated with ankylosing spondylosis. We'll be reading it in other chapters, in 3 further chapters. Trisomy 21, this is, everybody knows, it's Down syndrome, right? Mutation in CFTR gene, cystic fibrosis. Okay. Which of the following is not a feature of nephritic syndrome? Again, this is something we have already discussed. Hematuria, yes, it is a feature. Hypertension, yes, it is a feature. Oliguria also, yes. Massive proteinuria, no. Right, massive proteinuria is a feature of nephrotic syndrome. Okay, so next one. Next question, next short answer question is rapidly progressive or crescentic glomerular nephritis. Now, the pathogenesis is obviously severe glomerular injury along with crescent formation. You have to know what these crescents are. These are fibrocellular crescents. They consist of nothing but fibroblasts. Okay, you can see in this image over here. Okay, I'll just draw it for you. This is the glomerulus and these are the capillaries over here inside. And then here, there is a cap-like structure. Okay, there is a structure which resembles a cap here with many cells over here. This is what is known as crescent. Crescent is nothing but a half moon-like structure over here, which is made up of fibroblasts, proliferating fibroblasts. That is what a crescent is made of. And you can see the normal glomeruli and their capillaries here. That is what you can see here. So this portion is known as crescent. And whenever a crescent is present, it is known as a crescentic glomerulonephritis. Okay, just remember this much. Rapidly progressive, as the name says, this is rapidly progressive. So it's going to lead to acute renal failure. Okay, fine. Now, rapidly progressive glomerulonephritis has three types. First one, type 1, is associated with anti-GBM disease. Okay. Type 2 rapidly progressive glomerulonephritis is associated with membranous and membranoproliferative nephritis. Type 3 is associated with quasi-immune, like we already discussed the quasi-immune conditions, right? So type 3 is associated with quasi-immune. Type 1, anti-GBM disease, type 2, membranoproliferative, and type 3, quasi-immune. So these are the three types of crescentic glomerulonephritis. And remember what crescents are made of and how they look like. Now, Goodpasture's syndrome, we have already discussed enough. It is also known as anti-GBM disease. Okay, see, this glomerular basement membrane, it not only affects the kidneys, it also affects the lungs. So these patients have hemoptysis as well as hematuria. Okay, so hemoptysis as well as hematuria is what these patients have. Histopathology, we know it's going to affect the glomerular basement membrane, and what is going to be there? IgG antibodies are going to affect. So this is a immune-mediated disease. So they're going, when you do an immunofluorescence, you're going to see linear IgG deposits in the glomerular basement membrane. What are the complications? Since it affects kidney, renal failure, because this is also associated with crescentic glomerular nephritis, which is rapidly progressive. This can lead to renal failure. Pulmonary hemorrhage, because again, lung involvement is also there. So these are the few things which you have to remember about Goodpasture's syndrome. Now let's discuss a few MCQs again. What is the key histopathological feature of rapidly progressive glomerulonephritis? Right, easy crescents in the Bowman space. We already saw what crescents are, how they look like. Fibrinoid necrosis, no. Amyloidodeposition, no. Not even hypersclerosis. Goodpasture syndrome involves which antibodies against which structure? Very easy. Again, glomerular basement membrane. So it's Goodpasture syndrome is also known as anti-GBM disease, right? So anti-GBM disease and hence against the glomerular basement membrane. Fine. So I think we have covered most of the important things which can be asked in medical renal diseases and their pathology. So we'll see in the next class and discuss more of genitourinary system. That's it for today. Thank you so much.